Hi guys, welcome to FMG Marathon Part 2. So here we are going to discuss the high yield topics which were asked in previous year exams and last 5 years of FMG exam. So one by one we are going to discuss. First we are going to discuss intussusception. So you know what is intussusception? It is telescoping of one segment of bowel into another, and generally it is idiopathic. In which particular age group it is seen in 4 to 10 months of age. You tell me what is the most common type. If the question is asked that the most common type of intussusception, that is ileocolic, and if it is asked what is the most common type of intussusception in adults, so in adults it is colocolic, right? What are the parts of intussusception? Have a look. Here you can see there is telescoping of one segment of bowel into another, right? So this is recipient. Recipient means accepting segment. So this is intussuscipiens, and this is incoming segment. So this is intussusceptum. Where it enters, this is known as neck, and the terminal part, this is known as apex. Apex. So what are the parts of intussusception? First, recipient is known as intussuscipiens, okay, and incoming segment is known as intussusceptum. Where it enters, it's known as neck, and the terminal part is known as apex. Now question for you all, that what is the most prone to gangrene? Which part of intussusception is most prone to gangrene? Tell me, I'm waiting for your answer. Rakesh, Vish, Aishwarya Yadav, Chanchal, Vashist, S. Khan, Edu Global, Asha, most prone to gangrene. Yes, Shubham Deswal, you are correct. Sania, correct. Mansi, Vish, Lokendra, everybody is correct. Monu Chandel, no, it's not neck. PK Saini, Mohsin Khan, everybody is correct, almost everybody. So most prone to gangrene, this is apex. Apex is most prone to gangrene. We discussed that it is more common in children aged 4 to 10 months and it is idiopathic. Cause is not known. But in certain cases, there is a lead point, the point which initiates the intussusception. So another question for you all, that what is the most common lead point for intussusception? I am waiting for your answer. Tell me. Most common lead point for intussusception. I am waiting for your answer. Vikas, Saran, Asha. Asha is correct. MS, you are also correct. Yes, most common lead point for intussusception. Dr. PK Saini, Monish Khan, Putin, Sashi Bhushan, everybody is almost correct. The most common lead point, and that is Meckel's diverticulum. So it's the Meckel's diverticulum which is the most common lead point, followed by polyp. After that, this question was asked in 2 exams. Question was, sometimes tumor is responsible for intussusception. So tell me, what is the most common tumor responsible for intussusception? In children, it is lymphoma, and in adults, it is villous adenoma. Most common tumor responsible in children, lymphoma, most common tumor responsible for intussusception in adults, that is villous adenoma. Okay. So, whenever there is intussusception, you tell me patient will be having signs and symptoms of what? The most common type is ileocolic. So, what will happen? The ileum goes into the colon, and if ileum goes into the colon, there will be obstruction. It means majority of patients will be having signs and symptoms of small bowel obstruction. Since it is more common in children because there is colicky pain because of obstruction, so these kids are going to cry a lot at the time of intussusception. Why? Because of colicky pain. Since there is small bowel obstruction, so these kids are having multiple episodes of bilious vomiting. But what happens? Within 2 to 3 hours, there is spontaneous resolution. So, when attack subsides, patient becomes asymptomatic. So, in between attacks, the child is asymptomatic. But mother is going to tell you that after 2 to 3 attacks, patient is going to pass little amount of stool mixed with blood. If patient is going to pass little amount of stool mixed with blood, tell me what is the name of this stool? Yes, MS has already told us the correct answer. Satish Kumar, Satyam, Niyati, Chanchal, Kapil Dev, Chaudhary, Shubham Deshwal, PK Saini, Sashi Bhushan, everybody is correct. It is red currant jelly. What kind of stool? That is red currant jelly stool. That is red currant jelly stool. Clear? If you perform the examination, see the diagram. This is the patient. What happens? The ileum enters into the colon like this. So, in the right lumbar region, you are going to feel a mass here. You can feel a mass in right lumbar region. What kind of mass? In right lumbar region, there is sausage shaped mass in right lumbar region. And what happens? There is empty right iliac fossa. Tell me, what's the name of this sign? Empty right iliac fossa, what is the name of this sign? Yes, everyone, tell me. I'm waiting for your answer. Empty right iliac fossa. Very good fact. Sign of dance, Kapil Dev, sign of dance, Asha, Adil, Rahul, Lokendra, everybody is correct. It is known as sign of dance. Sign of dance. Okay. Now, another simple question. Tell me, which investigation is diagnostic and therapeutic in intussusception? Which investigation is diagnostic and therapeutic in intussusception? Simple question. Which investigation is diagnostic and therapeutic in intussusception? Yes. Now, see, it's very easy to understand. Here, I am going to give what? Can you see? Enema. And if you give enema, what happens? The obstruction is relieved because bowel comes out. So, which enema is preferred? Yes, we prefer air enema. Air enema is preferred over barium enema. Enema, it is both diagnostic as well as therapeutic. Air enema preferred over barium enema. Now, see the question. A child was brought to your hospital with intussusception. You have given air enema. The intussusception resolved. You discharge the patient. After 7 to 10 days, again there is recurrence. What will you do? Option, we will go for surgery. Second option, we will go for repeat air enema. If there is recurrence, what should be done? I am waiting for your reply. I am waiting for your reply. You will go for iliocolectomy, surgery or air enema? Yes. Everybody, majority of you are saying that, sir, repeat air enema, and that's correct. We have to go for repeat air enema. Now, imagine this time also you discharge the patient and again patient is having recurrence. What should be done? If there is second recurrence, what should be done? Tell me. Repeat air enema or surgery? I am waiting for your reply. Second recurrence, repeat air enema or surgery? Tell me. Asha says enema, but majority of you are saying that surgery, 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 surgery. Let me tell you, it's repeat air enema. Question. Third recurrence is an indication for surgery. So, here, whenever the patient is having recurrence, if the patient is having recurrence, in that case what we do? repeat air enema, repeat air enema. If there is third recurrence, patients who are having third recurrence, we perform surgery, and you people already told me what kind of surgery we do. What kind of surgery? We perform iliocolectomy. How we do? See the diagram. The diagram is something like this. This part is involved in intussusception. So I am going to remove this part. This part is removed. Ileum and colon is removed. Name of surgery, iliocolectomy. What kind of anastomosis? You know, you are left with ileum, you are left with transverse colon. So you perform anastomosis between ileum and transverse colon. What's the name? Iliotransverse anastomosis. So it is iliocolectomy plus iliotransverse anastomosis. Iliocolectomy plus iliotransverse anastomosis, that is the treatment. Okay. Which question is asked frequently in the exam? Various radiological signs. You tell me which signs are seen on barium enema. Tell me, I am waiting for your response. Signs seen on barium enema. I am waiting for your response. Everybody, Vikrant, tell me, Kapil Dev. Very good. Target sign. Okay. Barium enema, on barium enema, claw sign, and very good, coiled spring sign. This image based question is asked almost every year. Every year. First, see what? This is intussusception. Clear? In this, can you see? This is known as claw sign. Why this claw sign? See, this is the intussusception. So this part of bowel is not visible. And if this part of bowel is not visible, so this part looks like what? Claw. And when one part of bowel enters into another, here you can see, one part of bowel enters into another. So what happens? You can see the internal lining, and this lining looks like what? Coiled spring sign. These are two frequently asked image based question. What? Claw sign and coiled spring sign. It's the claw sign and coiled spring sign. Okay. Now you tell me, what is the most common site of volvulus? I am waiting for your answer. Everybody, most common site of volvulus, tell me. Most common site of volvulus. I am waiting for your answer. Yes, very good. Muhammad, Chanchal, Vinay Yadav, Adil, Jayant, Ankita, Vikas, Putin, Asha, Dr. MS, everybody is correct. It's sigmoid colon. So tell me, sigmoid volvulus is clockwise or anti-clockwise? Sigmoid volvulus, it's most commonly clockwise or anti-clockwise? Obviously it is anti-clockwise. So most commonly the sigmoid volvulus, it's anti-clockwise. Okay. There are two mandatory factors for sigmoid volvulus. First, there should be long narrow mesentery, and second, the patient should be having constipation, so that the sigmoid colon is going to twist. Here you can see there is twisting of the sigmoid colon. So what kind of obstruction is this? This is closed loop obstruction. It means these patients are having signs and symptoms of large bowel obstruction. And all of you know what are the signs and symptoms of large bowel obstruction? Tell me. Lower abdominal pain, that is colicky pain. Second, abdominal distension. And third, non-passage of feces and flatus, that is known as absolute constipation, also known as obstipation. So first, these patients will be having signs and symptoms of what? Large bowel obstruction. Clear? Now you tell me how you are going to make the diagnosis of volvulus, sigmoid volvulus. Simple question. You know that if a patient is having intestinal obstruction, in majority of cases we make the diagnosis by X-ray abdomen. We make the diagnosis by X-ray abdomen. In majority of cases, two views are required. One is supine and second is erect. Supine is better than erect. Supine is used for site of obstruction. Upright view or erect view, it is used for, yes, air fluid levels. So what are the signs seen? Tell me, easiest question. What are the signs seen in sigmoid volvulus? Everybody is correct. Coffee bean sign on X-ray. Very good. Apart from this coffee bean sign on X-ray, apart from coffee bean sign on X-ray, what are the other signs seen? Here you can see coffee bean sign. There is another sign. Tell me what's the name of this sign? Omega sign, and this is known as what? Bent inner tube. So there is omega sign, there is bent inner tube. All these signs are seen on X-ray. Now you tell me, what are the signs which are seen on barium enema? If we go for barium enema, what are the signs seen? I am waiting for your answer. Tell me guys. Bird of prey, Shashi Bhushan, very good. Bird of prey, MS bird beak sign, very good. Himanshu, very good. Bird beak, ace of spade sign, very good. Almost all of you are correct. So on barium enema, these are the signs: bird beak sign, ace of spade sign, bird of prey sign. Now here you can see this is what? Bird beak sign. Now listen the question carefully. Bird beak sign on barium swallow is seen in which condition? Tell me, bird beak sign on barium swallow is seen in which condition? Achalasia cardia, Shubham, very good. Asha, Himanshu, Anshu, Preetha, Rohit, everybody is correct. If it is barium swallow, the answer is achalasia cardia, and if it is barium enema, the answer is sigmoid volvulus. How you treat sigmoid volvulus? Since it is common in elderly patient, first when patient comes to your emergency, you resuscitate the patient, insert the colonoscope and perform colonoscopic detorsion. After performing colonoscopic detortion, when patient is stabilized, we are going to remove the sigmoid colon, sigmoidectomy. So what is the treatment here? First we perform colonoscopic detortion followed by elective sigmoid colectomy. We cannot leave patient only with colonoscopic detortion. Why? Because there is long narrow mesentery and this patient is prone to develop constipation, have constipation, that's why there is recurrence, and because of this we perform sigmoid colectomy. Okay? So all of you told me that sigmoid volvulus is anti-clockwise. Now tell me, cecal volvulus, it starts with C. Cecal volvulus starts with C. Tell me, it is clockwise or anti-clockwise? I am waiting for your response. Cecal volvulus, clockwise or anti-clockwise? Kapil Dev, MS, Chanchal, Aishwarya, Vikash, Kajal, Anand, pathologist Tanya, awesome, very good. Rohit, everybody is correct. C, cecal, C clockwise. So cecal volvulus, this is clockwise. See, in cecal volvulus, only cecum is not involved in torsion. Now see what parts are involved. You can see here, this is ileum, this is cecum, this is ascending colon. Since ileum, cecum, ascending colon, all of these are involved, the name is cecal volvulus. It's a misnomer. Correct term should be cecocolic volvulus, at least cecocolic, because apart from cecum, ascending colon as well as part of ileum is also involved. Simple. Now here you know that cecum is relatively fixed structure, only anterior part is mobile. So because of anything, if cecum is made mobile, like if a multipara patient is there, multipara patient, in multipara patient there is release of hormone relaxin. Because of that, ligaments are relaxed or laxed. Because of previous surgery, ligaments are divided. If there is malrotation, there is abnormal position of cecum, and if there is distal obstructing lesion, what happens? There is increased risk of torsion. These are the predisposing factors. Now you see this diagram, and just by looking at the diagram, you tell me when twisting occurs, these patients will be having signs and symptoms of large bowel obstruction or signs and symptoms of small bowel obstruction. I am waiting for your reply. Patients will be having signs and symptoms of large bowel obstruction or small bowel obstruction. Awesome, Blossom, small bowel, Sania, small bowel. Everybody got the concept, all of you got the concept that what? There is small bowel obstruction. Why small bowel? Because you saw that ileum is involved. When the twisting starts from ileum, obviously patient will be having small bowel obstruction. So in this patient, what will you find? You will find colicky pain, multiple episodes of bilious vomiting, and what else? Non-passage of feces and flatus. Clear? Again, how you are going to make the diagnosis? Simple. X-ray. Tell me, on X-ray this kind of finding is there. What's the name of this sign? On X-ray this sign is there. Tell me, what is the name of this sign? Which bean? This is also looking a bean. Which bean? What's the name of this bean? This is kidney bean sign. And there is another sign. This is comma shaped cecum. Kidney bean sign, comma shaped cecum. Clear? You cannot perform detorsion of cecal volvulus. So, whatever the part of bowel is involved in the rotation, you have to resect it. So, which part is resected? Can you see here? This part is removed. This part is removed. So, what? I am going to perform iliocolectomy. I am left with ileum. I am left with transverse colon. So, what should be the name of anastomosis? Surgery is iliocolectomy. You tell me what should be the name of anastomosis. I am waiting for your response. Yes, Gargi, Shet, correct answer. Himanshu, Lokendra, correct answer. What kind of anastomosis? Iliotransverse anastomosis. Clear? So, it should be iliotransverse anastomosis. So, we perform iliocolectomy plus iliotransverse anastomosis. These are two volvulus which are frequently asked. Now, one simple question. Tell me guys, what is the most tender point in acute appendicitis? Most tender point in acute appendicitis. Tell me. All of you know the answer. Most tender point in acute appendicitis. Vikas, tell me. Vish, Kavian, boss. It's not Murphy's sign. Murphy's in acute cholecystitis. McBurney's point, very good. Now you know that there is umbilicus. This is anterior superior iliac spine. I am going to join both of these points, and then at the junction of medial 2/3, lateral 1/3, this is the point. This point is known as McBurney's point. This point is known as McBurney's point. This is most tender point. McBurney's point. This is most tender point. Now, another question which was asked in NEET PG for the first time. This McBurney's point corresponds to which part of appendix? Tell me. Base of appendix or tip of appendix? I am waiting for your response. It corresponds to which part of appendix? Base of appendix or tip of appendix? Tell me. Rahul, Asha, Satyam, Vinay Yadav, everybody wants to say that base. Why? Because you know baby ko base pasand hai. How to remember? Baby ko base pasand hai. Got it? So now you will not forget. McBurney's point corresponds to base of appendix because you know base is fixed, the tip is mobile. This was the question in NEET PG. It corresponds to base of appendix. Okay. Another simple question is there. If I give the incision centered at McBurney's point, perpendicular to spino-umbilical line, what should be the name of this incision? Tell me. Obviously, what should be the name? What should be the name? Tell me guys. Yes? What should be the name? Incision centered at McBurney's point, perpendicular to spino-umbilical line. Yes, McBurney's incision, also known as MacArthur incision, also known as gridiron incision. And all of you know that this is muscle splitting incision. So the name of this incision, it's McBurney's incision. Also known as gridiron and MacArthur incision. What you have to remember, this is muscle splitting incision. Imagine this is the incision. These are the points. This was the incision. If I am going to extend the incision, can you see? Superolaterally, by cutting the conjoint tendon. I am going to extend the incision superolaterally by dividing or cutting the conjoint tendon. Tell me what's the name of this incision. If you cut the conjoint tendon, this muscle cutting incision, what's the name? Tell me guys. Name. Rutherford, Morrison, Gargi, correct. Fact, correct. Chanchal, Mukesh, yes. Gajender, Mansi, Vinay Yadav, Amritansh, Vish, Anupam Yadav, Rohit, Aishwarya, Awesome, Blossom. All of you are correct. That is Rutherford Morrison incision. And obviously, this Rutherford Morrison incision, it is used for which type of appendicitis? Retrocecal appendicitis, in which the appendix is hidden behind the cecum. So, this is retrocecal appendicitis. So, you give a larger incision, extend it superolaterally. So, this is what? This is a muscle cutting incision, and which structure is divided? We are going to divide conjoint tendon. After that, there is a cosmetically better incision. See how we give. This is abdomen, this is umbilicus. I am going to join midpoint of clavicle to midpoint of inguinal ligament. Midpoint of clavicle to midpoint of inguinal ligament. On this, I am placing one incision which is 2 cm below umbilicus, and it is transverse skin crease incision. Tell me what is the name? Sasi Bhushan, you are correct. Lange, also known as bikini incision. Very good, very good. So, this is, everybody is focused on the second part, not the lange. So, what's the name? It's lange incision, which is also known as modified McBurney's incision, also known as Rocky Davis incision, because the cosmetically, because scar is better cosmetically, that's why it is also known as bikini incision. Again, it is muscle splitting incision. Muscle splitting incision. And why this is preferred nowadays? This incision is preferred nowadays because there is better exposure and this is cosmetically better. Better exposure, cosmetically better. So, this is lange incision, muscle splitting incision. Very good. So, these 3 incisions you have to remember. I am repeating: McBurney's, also known as MacArthur, also known as gridiron. This is muscle splitting. Lange incision, also known as modified McBurney's, also known as Rocky Davis, also known as bikini incision. Again, muscle splitting. And you know, Rutherford Morrison is muscle cutting incision. And you can't believe this question was asked in FMG also, NEET PG also. These are 2 image based questions. One is related to Omphalocele, which is also known as exomphalos, and the second is related to Gastroschisis. First, let's discuss this Omphalocele. Omphalocele, you know, during development there is physiological herniation of bowel. So, when this herniated bowel fails to return to abdomen and it is covered by 2 layers, this is known as Omphalocele. Tell me what's the other name? Tell me guys, what's the other name? Exomphalos. All of you know that it is covered by 2 layers. There is one layer inside, one layer outside. Clear? Tell me which layer is inside. Out of amnion and peritoneum, which layer is inside? Which layer is inside? I am waiting for your reply. There is amnion and there is peritoneum. Which layer is inside? Yes? Somebody is saying amnion, somebody is saying peritoneum. Majority of you are saying amnion. Correct answer is peritoneum. And how to remember? It's pin. Whenever somebody is going to show you money, paisa in. So, pin. So, how to remember? Peritoneum is in. Now, you will not forget throughout your life, peritoneum is in, pin. So, which is inside? Peritoneum, outside amnion. Peritoneum is in, outside amnion. Okay? Problem. Here, bowel is covered. So, bowel related complications are lesser, but problem, this Omphalocele, it is associated with trisomies. Which trisomies? 13, 18, 21. associated with trisomy 13, 18, 21 and it is associated with congenital malformations. Which congenital malformation is most common? I am waiting for your reply. Tell me the most common congenital malformation. It is related to which system? Musculoskeletal, cardiovascular, genitourinary, which one? Most common, yes, Chanchal Vasist, correct. First person to answer Chanchal, very good. Then Vikas Prajapat, very good. Now, yes, cardiovascular, very good. So, most common congenital abnormality, cardiovascular. Because of congenital malformation, there is death of patient. That's why here, poor prognosis. The prognosis is poor. Poor prognosis is not related to bowel, it is related to congenital malformation. The second situation you can see here, bowel is exposed. You can see this is umbilical cord. On the right side of umbilical cord there is splitting of abdominal wall and protrusion of viscera. This is gastroschisis. Here bowel related complications are there. Bowel can become matted, edematous, but here it's not associated with congenital malformations. And since it is not associated with congenital malformation, relatively means if we are going to compare it with Omphalocele, here relatively there is good prognosis. Relatively there is good prognosis. I am telling you this question will be asked either gastroschisis or Omphalocele, and usually this is an image based question in exam. Clear? Now see, the questions related to kidney stone, first you tell me what is the most common renal stone. Tell me guys, I am waiting for your answer. Most common renal stone, tell me. Rishabh Kashyap, first person to reply. Sorry, first person. Now everybody is correct. It's calcium oxalate. Most common renal stone is calcium oxalate. Now another question for you people. Most common radiolucent renal stone. I'm waiting for the replies. Let's see who is going to answer first. Most common radiolucent renal stone. I'm waiting for your reply. First person. Let me see. Uric acid. Yes, it is Shubham. Shubham Deswal. Now everybody is correct. All of you are correct. It is uric acid. If you have seen the pattern of questions for the last 4-5 years, NEET, PG, FMG, even INI-CET, crystals are very important and image based questions are asked in relation to crystals. Okay. So first, most common type of renal stone, that is calcium oxalate. It is also known as calcium oxalate dihydrate. Tell me what is the shape of crystal. Shape of crystal you can see it is envelope shaped or bipyramidal. This is envelope shaped or bipyramidal, that is calcium oxalate crystal. Calcium oxalate means calcium oxalate dihydrate. If examiner wants to ask calcium oxalate monohydrate, he will mention monohydrate. If nothing is mentioned, you will assume that it is calcium oxalate dihydrate. So how monohydrate looks like? You can see here. This is calcium oxalate monohydrate. It is dumbbell shaped or hourglass. Have you seen hourglass? Hourglass in which the sand is coming down from the top part of the glass, hourglass. So this is dumbbell shaped, also known as hourglass. Calcium oxalate monohydrate. Clear? Frequently asked question. Now see third crystal, yes, the third one is, let me tell you, these are very important questions. Almost every year you will find at least one question from these images. Uric acid, this is most common radiolucent renal stone. And what kind of crystal is there? You can see it is multifaceted, like irregular plates or rosette shaped crystals. You can see here the shape, see the shape. Multifaceted, irregular plates or rosette shaped in uric acid crystal. Clear? Now staghorn, what are the other names of staghorn calculi? Struite stone, also known as triple phosphate stone, also known as calcium, magnesium, ammonium phosphate. Tell me what kind of crystal? You can see here how stone looks like. You can see how stone looks like horn of stag, because branching is there. You can see here there is branching. What is the shape of this crystal? Tell me guys. This is coffin lid. Awesome, blossom, very good. Coffin lid crystal, and let me tell you, this was the question asked in many exams. Coffin lid crystal in staghorn calculi or triple phosphate stone. Coffin lid crystal, image based question is asked. Now you tell me what kind of crystal is seen in cystine stone? Tell me what kind of crystal is seen in cystine stone? I am waiting for your response. Let's see who is going to tell me first. Cystine stone, what is the crystal? Shape of crystal? Yes, very good. Amritansh Ahluwalia, cystine hexagonal, very good. Hexagonal or benzene shaped, everybody is correct. It is hexagonal or benzene shaped. So here you can see this is the shape of crystal. Hexagonal or benzene shaped. This is hexagonal or benzene shaped. So this is the crystal. This is cystine stone. Cystine stone. So these are the crystals which are frequently asked. I am telling you, you will find one image based question. After that, tell me what is the location of bladder in the body? Urinary bladder location in the body. Tell me, where is the location of urinary bladder in the body? You know, it is in the pelvis. This is the abdomen. Here is the location of bladder. It is located in the pelvis. There are two types of bladder rupture. What? Extraperitoneal or intraperitoneal. You tell me which one is more common. Since bladder is located in pelvis, it's extraperitoneal location. So obviously most common is extraperitoneal, responsible for 80% of cases. Since it is located in pelvis, tell me what is the most common cause of extraperitoneal bladder rupture? I am waiting for your response. Everybody is correct. Extraperitoneal bladder rupture is more common. Yes, tell me most common cause. Since bladder is located in the pelvis, which fracture is responsible? Tell me guys. Road traffic accident, which fracture, which fracture, tell me. Yes, which fracture? Fracture. I gave you the hint also. Bladder is located in pelvis, which fracture? Pelvic fracture, very good. Pelvic fracture. So most common cause, road traffic accident leading to pelvic fracture. One by one we are going to discuss. First we are going to discuss what? Extraperitoneal bladder rupture. So it is caused by road traffic accident leading to pelvic fracture. Okay, you know that the posterior part of urethra is also located in pelvis, so sometimes it is associated with posterior urethral injury. Simple. Now, whenever the bladder will be ruptured, you tell me what will be the symptom? There will be suprapubic pain. If bladder is ruptured, patient is not able to generate adequate force for micturition, means difficulty in passing urine. And when patient is passing urine, urine comes with blood, mixed with blood, means hematuria. So what are the clinical features? There is suprapubic pain, difficulty in passing urine and hematuria. Now, I am giving you hint, you tell me the name of investigation. I inject the dye in the bladder and then take CT. What's the name of this investigation? I inject dye in the bladder, then take CT. What's the name of this investigation? Tell me guys. This is not RGU. Very good Chanchal. Chanchal, you are correct. MS, you are absolutely correct. What? You inject the dye, take CT. You inject the dye in bladder. It is graphy. Which graphy? Cystography. And if you take CT, it is CT cystography. So for bladder rupture, investigation of choice for diagnosis, cystography or cystogram, CT cystography. There are three signs: flame sign, pear sign, teardrop bladder. First you see this appearance. Tell me what is the name of this sign. How it looks like? Tell me. What's the name of this sign? Tell me. Flame, very good Shubham. Dr. PK Saini, Asha, everybody is correct. It is looking like flame. So flame sign. Now see the second one. What's the name? What's the name of this sign? Tell me. What's the name of this sign? Which fruit it looks like? Here you can see. Pear. Very good, Shubham. Shubham, pathologist, Himanshu, everybody is correct. This is pear shaped and this is teardrop bladder. Teardrop. So these are the signs. Okay. It is very easy to manage the extraperitoneal bladder rupture. Why? Because one tear is responsible for, one segment of fracture segment is responsible for tear of the bladder. So whenever there is tear of the bladder, what you do? You just maintain bladder in collapse state. So that tear is going to oppose each other. The tear margins are going to oppose and within 7 to 10 days it is going to heal spontaneously. So how you make bladder in collapse state? Nothing, just insert Foley's. So what we do? We decompress bladder by Foley's catheterization, and in majority of cases the spontaneous healing occurs within 7 to 10 days. Clear? So this is how we manage extraperitoneal bladder rupture. Now you tell me, what's the cause of intraperitoneal bladder rupture? There is one prerequisite. What? The bladder should be full. For intraperitoneal bladder rupture, the bladder should be full. Clear? An external blow or kick to the full bladder leads to intraperitoneal bladder rupture. It means it occurs when your bladder is full. Right? You have seen the party in boys hostel where they do party under the influence of alcohol and they dance also. Yes, under the influence of alcohol what happens? Yes, if you are dancing, it's uncontrolled sometimes and your bladder is full because alcohol is going to decrease antidiuretic hormone. So bladder is full and suddenly you received a kick or blow to your bladder. What? Bladder gets ruptured. So what will happen? The urine goes into peritoneal cavity. It means, what are the symptoms? Suprapubic pain, difficulty in passing urine, hematuria. Apart from hematuria, yes, what? Peritonitis. Apart from hematuria, these patients are also having peritonitis. Clear? So what are the clinical features? There is additional peritonitis. Again here we inject the dye in bladder, take CT. Investigation of choice is same. What? CT cystography. Now you tell me, if urine is there in your peritoneal cavity, what should be the treatment? Tell me guys, I'm waiting. I'm waiting for your response. If urine is in peritoneal cavity, what should be the treatment? You have to clean. You have to perform the lavage. Very good. Adiba, Vikas Chaudhary, Tanya. Yes, very good. Most of you are telling me the correct answer that we have to perform laparotomy. And after performing laparotomy, you perform the lavage. After performing lavage, what you do? You repair this bladder defect. You repair this bladder defect and then insert Foley's catheter or we perform SPC. So I'm repeating, what's the treatment here? In this case, exploratory laparotomy plus peritoneal lavage plus repair of defect, and after that suprapubic catheter insertion or Foley's catheterization. These are frequently asked questions in exam. Another image based question which is asked especially in FMG. Image based question, tell me, what's the name of this scar? What's the name of this one? The first one is, it is hypertrophic scar and this is keloid. There is one similarity in hypertrophic scar and keloid. What's the similarity? That in both there is presence of excessive scar tissue. In hypertrophic scar, this excessive scar tissue doesn't extend beyond the boundary of original wound or incision. So what? In both there are presence of excessive scar. Both there are presence of excessive scar tissue. It doesn't extend beyond the original wound or incision. Here it extends beyond original wound or incision. Okay. Now one simple question for you guys, you can see the image and tell me the correct answer. Most common site of keloid. You can see the image. Very good, Tanya. Very good, Tanya. You replied, and it's correct answer. Yes, it's sternum. Now everybody is responding and everybody is telling me the correct answer. It's sternum. And you see the keloid, it is seen in a triangular region. Can you see? Shoulder blades or shoulder tip and zip is sternum. So it is seen in this triangular region. Most common site is sternum. Another question, in which race it is more common? In white races or in darkly pigmented races? You can see the color of the skin. It is more common in darkly pigmented races. Okay. So what are the differences between hypertrophic scar and keloid? You can see keloid, generally it is seen in darkly pigmented races, so it can be familial. Hypertrophic scar is not familial, not related to race. There is no sex variation in hypertrophic scar, but keloids, these are more common in females. Hypertrophic scar, it's more common in children, but keloid 10 to 30 years. And we discussed keloid outgrows the wound area. And what is the most common site? Sternum. Apart from that, shoulder, it can be seen in the face, especially here, ear lobule. So some of the girls have multiple piercing in the ear lobule, especially in the darkly pigmented races. If some kind of piercing is done, some kind of surgery is being done in this area, this surgical stress increases the risk of keloid. And what's the problem with hypertrophic scar? If the incision is given over the flexor surface related to tension, means along the tension, so there is hypertrophic scar. Hypertrophic scar is generally seen within 4 weeks of surgery or incision, but keloid can be seen as early as 3 months up to 1 year. If you see the signs and symptoms, obviously this hypertrophic scar, it's raised. There is some itching or pruritus, but it respects wound confines. What happens in keloid? There is pain, there is pruritus, and it grows beyond the margin. Sometimes this question is asked in pathology related to histology. What kind of orientation of collagen fibers are there? Type 3 collagens. And what kind of orientation? Parallel. There is parallel orientation. And in keloid, both type 1 and type 3 collagen. And what kind of orientation? Thick wavy. There is thick wavy collagen. This is thick and wavy collagen. So hypertrophic scar, keloid, very, very important. Now another important question, EDH, SDH. Let me tell you one simple thing so that you are not going to forget throughout your life what's the difference between EDH and SDH. See, imagine this is the skull. In the skull, this is the brain. Between skull and brain, there is a pad. Can you tell me what is this pad? Between the skull and brain, there is a pad. Can you tell me what is this pad? Very good. D means dura, followed by arachnoid, followed by pia. So whenever there is collection of blood between skull and dura, it is known as extradural hematoma. And whenever there is collection of blood between what? Dura and arachnoid, this is subdural. In this diagram you can see this extradural hematoma, EDH. Here there is collection of blood, which artery is injured, middle meningeal, and in subdural hematoma, which artery is injured? This is the latest question. Which artery is injured? Cortical veins or bridging veins? Cortical veins or bridging veins? This is the latest question, guys. Can you tell me, out of EDH and SDH, which one is caused by significant trauma and which one is seen in elderly? After significant trauma, it is seen in elderly. Tell me which one. EDH, SDH, which one is more common in elderly after significant trauma? Gargi, you are correct. Yes, mixed response is there. Let me guys, it is SDH, not EDH. EDH can be caused by even trivial trauma to this area. This region is pterion. weakest point of skull bone, and this weakest point of skull bone, even trivial trauma can fracture this point. Beneath this pterion is middle meningeal artery. This middle meningeal artery can be injured. Let me tell you the typical history which is given in the exams. The typical history is elderly patient, sometimes male, sometimes female. In the night, patient is going to washroom and patient slips in the washroom, and then there is head injury. After that, patient is having headache, patient is having impaired neurological status. So after fall, head injury, there is impaired neurological status, headache, all these are findings suggestive of SDH. How to confirm the diagnosis? Take this patient for NCCT. Clear? So in EDH, important point, first EDH, it can be caused by trivial trauma. Trivial trauma to which point? To pterion. It is caused by injury of which artery? You know, EDH is caused by injury of middle meningeal artery. You know that lucid interval is positive. Let me give you the example which was asked many times in FMG exam. Question which was asked in FMG exam, see. A football player during playing football suffered injury to this area, head injury. He felt unconscious or became unconscious. He was on the ground for 5 minutes, again became conscious, played football for 10 minutes and became unconscious. So what is this lucid interval? One episode of consciousness between two episodes of unconsciousness. So this lucid interval is positive. SDH, it is seen in elderly after significant trauma, and it is caused by, this is the question, you have to remember guys, this is the question, injury of cortical veins or bridging veins. It is caused by injury of cortical veins or bridging veins. In both of these, investigation of choice for diagnosis NCCT. And this CT picture is asked almost every year, sometimes in medicine, sometimes in surgery, sometimes in radiology. Tell me what kind of appearance? Tell me what kind of appearance? In EDH you can see there is biconvex hyperdense lesion. There is hyperdense lesion. What kind of? This is biconvex hyperdense lesion, and here concavo-convex. This is concavo-convex hyperdense lesion. Very good, very good. This is also known as crescent shaped. This is also known as lemon shaped or lens shaped hyperdense lesion. If there is blood, in most of the cases when there is significant collection of blood, we have to drain it. So how you can drain it? You can drain it by a hole, burr hole. You create burr hole, or you can go for craniotomy. So how we are going to drain it? By creating burr hole or by craniotomy. This is image based question asked almost every year. Every year. Clear? And let me tell you one question which is asked in each and every paper every year. In NEET, PG, FMG, AIMS, in each paper this question is asked, and the question is tension pneumothorax. What is the cause of tension pneumothorax? It is caused by one-way valve air leak. One-way valve air leak means because of penetrating trauma or blunt trauma, this kind of valve is formed. Here you can see in the diagram. If there is one-way valve air leak, can you see? On inspiration, when your chest cavity moves out, there is negative pressure, you can see that air comes in. And when on expiration, there is positive pressure, chest cavity moves out. Now see it again. Whenever you do inspiration, chest cavity moves out, there is negative pressure, air comes in. During expiration, this chest cavity moves in, there is positive pressure, valve is closed. It means air only comes in the thorax, it is not able to escape. Means air is collected under tension. Second, whenever there is injury to lungs, what will happen? Here also, what's the problem? When lung is expanded, the small tear becomes large during expansion. So, there is air leak, and during expiration that large opening becomes small. So, air is not able to escape. It means ultimately air keeps on collecting in the pleural space and it keeps on collapsing the lungs. After that, there will be depression of diaphragm. After that, it will compress what? The veins, major veins. So, what are the pathophysiology, means what are the manifestations in tension pneumothorax? Since there is collapse of ipsilateral lung, so these patients are having respiratory distress. And if patient is having respiratory distress, obviously at the time of presentation, what? Patient is having dyspnea and patient is having tachypnea. Let me tell you, this question is asked every year. There is shift of mediastinum to opposite side. There is depressed diaphragm, decreased venous return. Why? See the diagram. If you see this diagram, it is going to compress what? You can see here. It is going to compress IVC. It is going to compress superior vena cava. So, venous return is decreased, that is why there is reduced cardiac output, and that is why patient is having low BP, means hypotension. But if you see this neck veins, what? Since the veins are compressed, major veins, you have seen or you are going to see distended neck veins. So, this is very important. Because of decreased venous return, there is decreased cardiac output, that is why there is decreased blood pressure, means patient is having hypotension, but these patients are having distended neck veins. Distended neck veins. Okay. If you are going to perform the percussion and auscultation, see here the hemithorax is containing air. If you do the percussion, there is hyperresonance. If you are going to perform the auscultation, there is absent breath sounds. So, hyperresonance with absence of breath sound. Now, one simple question, you tell me, what is the investigation of choice for diagnosis of tension pneumothorax? Investigation of choice. It is chest X-ray or it is CT? I am waiting for your response. Tell me guys. I am waiting for your response. Investigation of choice for diagnosis. It is chest X-ray or CT? Chest X-ray or CT? Yes, most of you are marking chest X-ray. Some of you told me the correct answer. It's clinical. Whenever you suspect tension pneumothorax, don't send the patient to radiology department. If you will send the patient to radiology department, you will send the patient, but you will receive the body. Why? Because patient might die in radiology department. It's an emergency. So, on the basis of suspicion itself, if patient is having dyspnea, tachypnea, distended neck veins, there is hypotension, there is hyperresonance and absent breath sounds, just on the basis of this clinical finding, we have to put a wide bore needle. You tell me in which intercostal space? Wide bore needle in which intercostal space? In children, all of you know that we put wide bore needle in second intercostal space. In second intercostal space, in which mid clavicular line? Mid clavicular line. But if you see adults, this is changed. According to latest ATLS guidelines, in adults we are not inserting the needle in second intercostal space, we are inserting it in fifth intercostal space. So, in adults it is fifth intercostal space, in which line? This is anterior axillary line. You have to remember, it is anterior axillary line. Very good, anterior axillary line. And all of you know what is the treatment of choice? ICD insertion, means intercostal drain or chest tube insertion. Where? In fifth intercostal space. In fifth intercostal space. Where? In triangle of safety. Fifth intercostal space in triangle of safety. Very good, very good. And somebody is telling the size of catheter also 16 gauge. Very good. So, in triangle of safety. Let me tell you, this is the question which is asked every year. Every year this question is asked. Sometimes they ask the diagnosis, sometimes they ask the management, the clinical description is given. Now, one liner questions related to blunt trauma abdomen. All of you know the answer. What is the most commonly injured organ in blunt trauma abdomen? All of you know. It is spleen followed by liver. But if it is penetrating trauma, most commonly injured organ in penetrating trauma, then it's liver followed by stomach followed by small intestine. Suppose somebody fired a bullet to the abdomen, means in gunshot wound, what is the most commonly injured organ? Then it's small intestine. Simple question. What is the most commonly injured part of bowel in blunt trauma abdomen? Bowel. The part of bowel should be fixed also, and the part of bowel should be mobile also. Which part of bowel is fixed and mobile? Both. Jejunum, because jejunum is fixed at DJ, rest part is mobile. So, most commonly injured part of bowel in blunt trauma abdomen, that is jejunum. Jayant, Shahrukh, Kishore, Awesome Blossom, Tanya, Monish, Kapil Dev, everybody is correct, it's jejunum. And suppose suddenly brakes are applied, that is deceleration injury. So, which junction is injured? The junction where bowel is fixed, DJ. You know seat belt injury? So, tell me which structure is injured most commonly in seat belt injury. I am waiting for your response. In seat belt injury, yes, Advacelum, very good. Advacelum, you are correct. Most commonly injured organ, Himanshu, you are correct. Tanya, very good. Everybody is correct. Most commonly injured organ in seat belt injury, mesentery. Now you tell me, any patient of blunt trauma abdomen is brought to your emergency. Doesn't matter patient is stable or unstable, doesn't matter. What is the first investigation done? Yes, Amritansh, you are correct. Kapil Dev, you are also correct. Now everybody is correct. Asha, medical dream, yes, everybody. Fast, doesn't matter whether the patient is stable or unstable, we go for fast. Second, only in stable patients we have to confirm the findings with CT. So, what is the gold standard investigation for stable patients of blunt trauma abdomen? CCT. That is CCT. Clear? In blunt trauma, one investigation which is crucial, first, fast. Tell me what is the full form of fast? All of you know the correct answer. Focused assessment with sonography for trauma. What is this fast? This is ultrasound which is done very fast. Kitna fast? Within how many minutes? So, it is done within 2 to 4 minutes. It is nothing, it is ultrasound which is done very fast within 2 to 4 minutes. And what we have to assess 4 P's. So, how to remember? 4 minutes, 4 P's. What are those 4 P's which are assessed? Yes, you can see here. Pericardial sac. Second, perihepatic region. Third, perisplenic region. And fourth, pelvis. In this sequence we assess. So, this is pericardial sac, this is perihepatic region, this is perisplenic region, this is pelvis. So, how many views? In fast, 4 views. Then there is a question, E fast. How many views are there in E fast? E means extended fast, which is going to extend or going to involve right and left thoracic view. So, tell me guys, Satyam Alok, very good. E fast 6, everybody is saying that on E fast there are 6 views. Now, one repeat question I am asking. A repeat question I am asking, that if a patient is having pneumothorax on E fast, what is the name of sign? Tell me. Tell me guys, what is the name of sign? Gargi, correct. Tell me the name of sign. Anushka, you are also correct. Tell me the name of sign. Chanchal, very good. Mamu, Sanjay, Monish, yes, all of you are correct. This is barcode sign, also known as stratosphere sign. There is barcode sign, also known as stratosphere sign. Stratosphere sign. Clear? So, these are important questions related to fast. Another important topic which is asked frequently, that is sutures. Tell me the name of the suture. Just by looking at the color of packet, you can identify. And let me tell you another hint. On the packet, name is mentioned. Whenever this packet is given in the exam, the name is mentioned, you can see. So what is the name of the suture? Catgut. It is catgut, but it is not prepared from catgut. It is prepared from sheep gut. Which layer? Sheep's submucosa. And which part of bowel? Ileum. So it is prepared from submucosa of sheep's ileum. It is preserved in isopropyl alcohol. Isopropyl alcohol. Tell me in how many days catgut is absorbed? This is the question. Guys, tell me in how many days catgut is absorbed? It's a question. Everybody is telling it correctly. Isopropyl alcohol. Yes, that's the solution used. In how many days it is absorbed? This is the question. Yes, Sanjay, very good. Sanjay, first person to reply. And now everybody is replying correctly. It is 60 days. It is absorbed in 60 days. Clear? Now see the next one. What is the name of this suture? It's written. Can you see here? Vicryl. And what is the other name of vicryl? This is polyglactin. Polyglactin. This is workhorse suture of general surgeon. If whenever you will do your internship, you will see in surgery OT that general surgeon is, just he is shouting for this suture, vicryl, 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 vicryl. So this is vicryl. In how many days it is absorbed? Vicryl. Yes, I am waiting for your response. This is polyglactin. This is polyfilament suture, and this suture is specially used for the organs in which there is stone forming tendency. What are the organs in which there is stone forming tendency? CBD, ureter, bladder. For CBD, ureter, bladder, we use vicryl. Tell me guys, in how many days it is absorbed? Pratibha, correct. Tanya, correct. Muhammad Rafiq, correct. All of you are correct. 60 to 90 days. Again, it is absorbable suture, absorbed in 60 to 90 days. That's vicryl. Now see the color and tell me what's the name of this suture. It's written here. You can see easily. What's the name? It's proline. Other name of proline, here also it's written polypropylene. Proline. Tell me guys, this is absorbable suture or non-absorbable suture? Proline is absorbable suture or non-absorbable suture? Tell me guys. Non-absorbable. Very good. All of you know that it's non-absorbable suture. Now tell me the uses. Whenever you will go to the OT, you will see that when we perform laparotomy, for suturing of rectus sheath, we are using what? Proline. And second, for vascular anastomosis, it should be watertight. We are using proline. So proline is non-absorbable, used for vascular anastomosis. It is used for vascular anastomosis and used for suturing rectus sheath. It is used for suturing rectus sheath. These are important sutures which are asked in exam. Another question which is asked frequently, that is, which suture is absorbed in how many days? You have to remember. So which suture is absorbed in 60 days? You told me already. Catgut. Which suture is absorbed in 60 to 90 days? How to remember? Mnemonic is VCD. Full form V, that's vicryl. C, this is chromic catgut. D, that is Dexan, also known as polyglycolic acid. Polyglycolic acid. And which suture is absorbed in 90 to 120 days? You tell me guys, I'm waiting for your answer. Which suture is absorbed in 90 to 120 days? 90 to 120. No, it's monocryl. Very good, Chanchal. Monocryl. This is also known as polyglycaprone. This is polyglycaprone 90 to 120, and in 180 days, which suture is absorbed, that is PDS, that is polydioxanone. This is polydioxanone. PDS, this is polydioxanone. Clear? So these are important topics. These are important topics frequently asked in exam, and let me tell you, from this FMG marathon part 1 and part 2, definitely you are going to get minimum 10 to 15 questions minimum in exam, minimum. So all the best, guys. Yes, thank you for your participation. This kind of beautiful audience is there with active participation in this FMG. I hope your preparation is going better and better day by day. You are putting your 100%. Thank you very, very much, and best of luck for your FMG exam.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe